To begin our discussion today on upper extremity arteries, it's first important to understand what kind of test you should do. And I think the type of test you do is really determined by the question you want answered. When we come to arterial testing, I really think the first question should be, is there arterial disease present? It's a yes or no answer to this question. And I think that physiologic testing will tell us the easiest and the quickest of whether or no there is disease or not. Once we find out a patient has vascular disease, then we can use ultrasound to actually better define the disease, the location and severity, and that's where ultrasound really comes into play. Peripheral arterial ultrasound, we know, can exactly identify what piece of the anatomy we're looking at. It can tell us a particular point where there may be something abnormal. Having that information, we can help the clinicians then direct additional intervention for their patient, whether that's angioplasty and stent or surgery. But this can be direct information from the ultrasound that they can utilize for therapy. We know we can follow disease progression. We do that all the time with carotid vessels. And one of the best things about ultrasound is that we can differentiate stenosis from occlusion. We can't do that on the indirect tests. We know that we can get a very high-grade stenosis or have a vessel completely occluded and get similar results, but we can see that difference on ultrasound. And ultrasound is great because we can get that anatomy that I discussed, but we can get the physiology. We can look at velocity waveforms and shapes, and we know what is going on both at that point and what is going on in the tissue bed being supplied by that vessel. Well, in terms of upper extremity arterial disease, it's certainly not all that common. In fact, it only accounts for about 5% of all symptomatic extremity disease. It's pretty uncommon for us. Atherosclerosis is a player, but it's relatively rare, and that most of the upper extremity arterial disease we see actually can be caused by a variety of other diseases, and they're listed here. Some of them include, as I said, atherosclerosis, but various types of arteritis or embolic disease, traumatic disease, and thoracic outlet. These are problems in the large upper extremity arteries and large arterial diseases, and it only accounts for 5 to 10% of the patients. In this figure over here, we see a vessel. This actually happens to be a common carotid artery, and we can see this diffuse buildup in the wall here, and that's very typical of a patient with arteritis. We'll come back to that in a second. Well, small vessel disease is really the bulk of what we see in the upper extremity, and that's almost 95% of the patients. The testing we do there actually can vary depending upon what's going on. Certainly we'll see some patients who may have vasospastic diseases, and they can be the result of true Raynaud's disease or Raynaud's phenomenon. We also see patients with connective tissue disorders such as scleroderma or lupus or rheumatoid arthritis. Other patients may have coagulable states. They may also present with Berger's disease or various other types of problems, including frostbite or some sort of neoplasm or vibrational injury, which is actually quite common in patients who are laborers and use pneumatic tools to do their job. They can get diseases within the small vessels of their upper extremities. Now, a minute or two here about Raynaud's phenomenon. Many patients have this multicolored change that their hands, their fingers go through. Sometimes we don't know why. That's only a small percentage, maybe 5 to 10% have primary Raynaud's disease. We really have no clue what's going on. Most patients present with Raynaud's phenomenon, which is secondary to a number of underlying causes, such as connective tissue disease, thoracic outlet, etc. And the patients go through this classic colorful pattern of changes. First, the digits are white, they blanch. The artery will vasospasm and shut, and there's no perfusion here, so the fingers blanch. Secondly, what happens is the blood remaining in the tissue becomes deoxygenated and the tissues become cyanotic or blue. Lastly, once the stimulus is removed, the arteries stop vasospasming, blood flow is returned, there is a reactive hyperemia here, and we see this bright red change. So we go from white to blue to red, and we get this classic pattern we see in patients with Raynaud's. Now, in terms of the upper extremity assessment, why do we ever wind up doing ultrasound on some of these patients? Well, probably one of the big indications would be to look for subclavian artery stenosis. Again, large vessel disease is not common, but it can occur. Most patients with subclavian artery stenosis remain asymptomatic. They don't even know they have it. It's picked up incidentally by differences in brachial blood pressures. Also, the few patients that I've been told that can develop symptoms due to subclavian artery stenosis are those who use their arms for their living, such as a hairdresser or something like that. They're constantly moving their arms, and they may develop some symptoms as a result. Also, in patients who've had a CABG in which they've used the left internal mammary artery as a conduit, if there's a left subclavian artery stenosis, this can spell trouble for those patients as well, and they can actually get angina as a result. Probably more commonly, we're seeing upper extremity evaluations done for patients undergoing radial artery harvest for a CABG or in a pre-op evaluation prior to the creation of a dialysis fistula. Certainly, we can also identify hemodialysis access grafts and fistulas, looking for a stenosis and such, but that topic is best reserved for another lecture. We do see patients, though, with dialysis access sites who can develop arterial steels. And lastly, we can also see patients for thoracic outlet syndrome, although in those patients we may not be doing an ultrasound as their arterial assessment. This sketch here just shows the normal upper extremity anatomy, and once we get out onto the arm, it's a pretty easy scan of the brachial and the radial and the ulnar vessels. Where the challenge comes is right here at the base of the neck because of the sternum and the clavicle hiding portions of the brachiocephalic and subclavian vessels. It may be a challenge to get through all these vessels. If you have the availability of a curved linear array, that transducer will help insunate these vessels near the clavicle. We're usually going to use a mid-range transducer for some of the subclavian evaluation. If we're looking on the forearm at the radial and ulnar arteries, we're probably going to use a high-frequency transducer in order to see those smaller, more superficial vessels more clearly. We're going to look for the same things like a stenosis, calcification, wall thickening. We're going to record the peak systolic velocity as well as vessel diameter, and in some instances we may be asked to measure volume flow, which I'll explain in a few minutes. Now, an artery is an artery, and a normal artery should look nice and thin-walled, be smooth, and have an appreciable intimomedial boundary that we can see. As we get various levels of disease, we'll see plaque and calcification and so forth. Here is a nice normal artery, companion vein underneath, and we can see nice, thin, smooth walls, no irregularities. We see a small collateral side branch up here, as opposed to these vessels, which have significant disease. Here's a radial artery down in the forearm with this intermittent calcification noted here. Sometimes it's very hard to tell whether or not this is somebody that's borderline, that perhaps this could be used. Obviously, if we see extensive calcification, that vessel is not suitable for use as a conduit. But this little intermittent calcification, if you can compress that artery closed with the weight of the ultrasound transducer and pushing down, and we can compress that closed, we probably still have enough compliance that the vessel would be suitable if they had no other conduit. Now over here, here's another example of a diseased artery. This is a copy of a copy, so it's a little bit grainy, but we can see this person has an arteritis, and there's this uniform thickening to the vessel wall. It doesn't look like plaque at all, and that's very common in patients with an arteritis.